Thanks for joining us to help choose home when care is needed, a podcast all about the benefits and values of receiving care in a place that you likely feel most comfortable, wherever you call home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Each episode, I'll be talking with a guest who will help us in our quest to educate about healthcare at home. So let's get started. Today's episode is number 11, and this is the first part of a two-part series with our guest, Arnie Cisneros. Arnie's president of Home Health Strategic Management, and he's been involved in home care as a physical therapist and as a consultant to the industry for over 30 years now. And he primarily focuses on quality. Instrumental he was in spearheading one of the nation's first accountable care organizations. And this is in an era when government is looking to lower costs while maintaining quality. I know that quality has been at the forefront of what you've been focused on, and also accountable care organizations. So within those two areas, if you were to tell consumers something they needed to know about choosing home, what would that be?
Well, I certainly think that the home is the care delivery floor of the future. And I think that there's clearly efforts moved in that direction. And I think when we really look at what Medicare has done with their model over the past 30 to 40 years, it's all been headed towards decreasing inpatient admission volumes and trying to make sure we could deliver care in the least constricted environment. And that started in the 80s when they put DRGs into the hospital mechanism, and hospital length of stays decreased from 17 days to 3.8. And that ultimately sent many of the patients who were getting care in the hospital into post-acute settings like skilled nursing facilities and home health. And I think that's when the concept of delivering care at home really started to take root with Medicare. And over the next couple of decades, just evolving the care delivery model, hospital admission followed by a nursing home followed by home care, has really brought what we can provide in the home to the forefront. And it becomes a much simpler question than I think any of us think about. And certainly I've delivered home health visits for 35 years, and I realized that what I thought in the early 80s when I saw a patient who had been in a hospital for nearly 3 weeks was wildly different than what I think about a patient now when they come out of the hospital in about 4 days. And I think that's reflective of where we're all headed. When you really take a long step back and think about the things that happen in an acute care admission versus what can happen at home, much of that, if not most of that care, can be substituted into the home environment through telehealth and monitoring and working with patients and their caregivers to address more troubling and concerning medical elements like med management and care maintenance at home. So I think we're really headed towards that, whether we're prepared for that or not. And I think that that's really an exciting thing for the home delivery model. I think that's an exciting thing for the patients. I remember that from the very beginning of home care, I looked at some of my geriatric clients and thought that my job was to deliver them the ability to spend their remaining days at home rather than in a nursing home or in a facility or somewhere else. And I think that that's really come to the forefront about what we can do in the future to really dominate the healthcare world. I actually think we will be the intake into acute care within a decade, and I think we will be the group that's resolving the care program towards discharge at home in many instances.
Well, that's really interesting. So walk me through the scenario where the care would start at home versus how it is right now.
Well, I think that what we're looking at, especially through generally the ACO and the episodic care model, is the fact that we want to, again, provide the most cost-effective and affordable provider at any spot of the care site. So let's presume that an ACO has 40,000 patients in a population or chronic health program, and one of those patients needs to feels they need to be admitted to the hospital. That ACO, if they're progressive, will send a home health nurse out to the home in the future to do an assessment. and determine whether that patient needs to go to the hospital, whether they need to be admitted into a SNF, or whether they're able to address the care concern at home. So I think that that's an example of how we're going to be moving forward. Some ACOs at this point have home health work with the SNF to help promote telehealth management between the hospital discharge and the home health admission, and that model alone has decreased in the SNF length of stays because it starts to characterize the SNF program in some terms other than the way that SNF looks at care delivery. Now all of a sudden they've got a home health provider, and how home health providers look at care delivery is part of their programming, and that, again, quite consistently brings people out of the SNF faster. In my early years, in the mid-'80s, I would be seeing patients at the SNF, and I would see patients later in the day in home care. And many of my SNF patients would comment, "Man, I wish I could get this care at home." And my response would be, "I've got three patients right now who are more involved than you receiving this care at home." So I think that that's really where our opportunities lie, is that we, as providers at sites on the care continuum, we don't think about other providers. I mean, what happens in our ACO bundle is that the hospital learned that they didn't need to keep people in the hospital for 3 days in order to stabilize them and get them to a SNF if they were going to a SNF. And I think that occurs at every level, including home care. When we did a post-acute PPS trial with one of the pioneer ACOs last year, we decreased our SNF length of stays by 68%. Well, we know where all those patients went. They went to home care. So that's really an opportunity for us to shoulder that care utilization that we're not getting now, and to accept it in the home. I do think we will also, and I think we've experienced this in some of our bundles, particularly the orthopedic joint replacement bundles, for the first time we're going to lose the tail end of some of our cases. Joint replacement patients are being reduced to, in some cases, LUPAs or 6 or 7 therapy visits, where as recently as 5 years ago they were an average of 13 to 18 therapy visits. So in a manner that we're not used to, we're going to lose some of the back ends of our programs to outpatient. And I think that that's all reflective of our need to focus on quality components and making sure that we polish our quality assessments and care delivery models, because I think that's where all post-acute care providers have exposure. Sometimes, because we're not used to sitting at the acute care table and dealing with acute care programming concepts, we fail to have our answers prepared for some of their value questions. And I think that's very common across the post-acute care continuum, so I don't think we're any different than anybody else. But I do want to comment that when I worked with a couple of the pioneer ACOs, I worked with 2 of the major hospital chains in America, Vanguard and Tenet. And both of those chains have not been circumspect about their belief that 10 to 15 years from now, 80 to 85% of care delivery in America will be through the home care delivery model.
I didn't realize those projections had been made, and based obviously on historical data.
Correct. And I think that that's, as many of us in our industry kind of consider that a potential programming burden, as opposed to the complement and the recognition that it is from Medicare that we've been complaining about not receiving for decades. It's a feather in our cap that somebody would say, "I think you guys can take care of this."
It's right, in a huge percentage of cases. So I want you to define a few terms, because this is a consumer-focused podcast. So accountable care organizations, you're calling them ACO. Can you just do a brief description of what an ACO is?
Well, an accountable care organization, from today's perspective, is really an opportunity to address the value quotient of the healthcare dollar. So an accountable care organization is really a health system that's committed to manage a patient through a physician for all their care needs. And what I would describe it as, and I think that this is a positive, is that previously in our healthcare careers, merely, we dealt with health maintenance organizations, which were HMOs. And those HMOs took on patients and managed them clinically, and then they also managed them financially. But they weren't providers. They were just insurance companies. So there, oftentimes those HMOs went belly up in the long run because they couldn't marry the financial management with the costs of care delivery. So in a manner of speaking, an ACO is an HMO owned by a health system or a health provider. I guess usually it's a health system. Sometimes it's MDs who own the ACOs. And they manage you, but they're responsible for the care costs and the care delivery as well. So what they're really looking for, and I think that it's important for the consumer to understand that the key term here is accountable. And what the Accountable Care Organization or the ACO model wants to do is make the provider accountable for the care cost of the care that they're delivering to the patient. So Medicare says to the provider, this is what we think your care costs will be if the patient is managed efficiently, and they pay the provider that money up front. And then if the provider is able to manage the care in a cost-effective manner, they get to create a margin after their care delivery that pays them to treat the patient. And if they're inefficient, they don't get to rebill Medicare for more funds, which is what we do today. So the Accountable Care Organization seeks value. And I'll give you an example of how these value decisions work for the patient quite consistently. When I worked with the Pioneer ACOs in the Detroit Medical Center, we were awarded a bundled pilot program by the Medicare Innovation Center for joint replacements. And because we had to, let me describe to you financially. They basically, and these are kind of gross numbers, they basically figured that they paid us about $30,000 for a joint replacement to the Detroit Medical Center for what it cost to do the surgery, put the patient into the hospital, and pay for care 30 days after the hospital discharge. And they told us that instead of paying us $30,000 in this bundled payment pilot, they were going to pay us $22,000. So we had to find savings right off the top. And anything that we were able to create that resulted in a care cost under the $22,000 they paid us was going to be our margin. So we just went right down the list, and this is the kind of things that maybe it didn't feel that way to the first patient who went through, but after a while it was recognized by the patients as an opportunity. Instead of 3 days in the hospital, our hospital length of stay came down to 1.9. So you were out of the hospital with basically a one-night stay rather than 2 nights of stay in the hospital. And the statistics are quite consistent about that, Marilee. The longer you're in the hospital, the more likely you are to get a reinfection or any number of other problems that inpatient hospital beds confront. And then rather than spending an average of 19 days in the SNF, our SNF length of stay dropped to 8 days. And rather than being on a home health program for 3.5 weeks and receiving anywhere from 12 to 15 visits of therapy, you were on a home health program for 13 days, and you averaged 6 visits of therapy. And then you were out into outpatient, which is how joint replacements really get back into society, before the end of the 3rd week, as opposed to maybe the 4th week or the 5th week. So the patient got better faster, out of the hospital faster. If they needed to be in the nursing home, they were there less time. If they needed to be in home care, they were homebound for a shorter period of time, and they were on to real function with their joint replacement faster than, literally 30 to 40% faster than it occurred currently for the previous 5 years. Now, I think joint replacements are good patients to decrease some of these utilization levels on, because usually when you're treating a joint replacement patient at home and you're doing exercises with them in their living room, they're watching traffic go by outside, because that's why they got their joint replacement, is to get out there. So they're highly compliant and they're highly motivated patients. But this exists all across the board with ACOs, and I will give you an example of more of a chronic patient that the Detroit Medical Center was able to make this work for. So they have 40,000 chronic care patients, which are patients they take on and are paid at the beginning of the year by Medicare to manage throughout the year. And again, I'm going to give you gross numbers, but they had a patient who in the previous year, 2011, had been admitted 5 times to the Detroit Medical Center. Each admission was for CHF exacerbation. And each time that they were stabilized and returned back to the community, home health was ordered. And home health came in, and I'm sure they did a decent job. And as soon as home health left, the patient stopped managing their CHF. They had an exacerbation, and they went back to the hospital. So they cost Medicare $110,000 that year with those 5 hospital admissions and post-discharge care. This patient, we'll call him Patient A. Patient A, the CHF patient, uncontrolled, was then assigned to the Detroit Medical Center as a chronic care patient. And the Detroit Medical Center received approximately $105,000 up front from Medicare to care for this patient for the entire year. Now, Medicare says to the Detroit Medical Center, in effect, if you wait for this patient to get sick 5 more times and follow the traditional model of admitting them to the hospital, treating them in the hospital, crossing your fingers and sending them home with home care until they come back again, your cost will be in excess of $130,000, and you only have $105,000 to cover that. Now, I remember when I first heard of this program, Marilee, I had the cynical home health veteran thought, well, they're not going to solve CHF on a patient, but they don't need to solve CHF on a patient. They just need to decrease 5 admissions to 4 admissions or less. And if they do, because they get that patient to take 1 or 2 steps towards self-control over her CHF and management of her diet, her water weight, and her diuretics, that you could easily see a reduction from 5 to 4 or even 3 readmissions. And I think that that's really what we're headed towards. Is it's not just about ordering home health. It's not about did you give them a home health referral and did they get a home health episode, but what is the accountability of the expenditure we made on home health? Did they improve this woman? Did you get somebody to get her to write down her diet? Did you get somebody to connect her to taking her weight on a daily basis and transcribing it so we can manage it through that model? And the answer to that ultimately was yes. We were able to deliver clinicians who were able to do that. But stop and think about what clinicians you're going to send. Are you going to send the clinicians from the home health agency that did the 5 episodes the year before and somehow couldn't change this woman's CHF control? So these are the questions that exist around home health, but really should drive patients and their families to understand the opportunities of home health. Patients get better faster at home health. Patients are more compliant in the home. Patients enjoy the care more while it's in the home. But I think we have to now marry that to the value of our delivery. And for the patients who are listening, when you get opportunities today, you really want to work hand in hand with your caregiver, regardless of what care setting that is, but particularly in the home, because their focus is on you staying in the home. And things that may or may not be their first choice of how to spend their leisure time at home, such as taking your water weight every day if you're a CHF patient, when connected to the fact that this could keep you from going to the hospital twice a year, I think that's really, the value is evident along those lines. And though some people feel more comfortable in the hospital, very few people who are leaving the hospital ask to stay. And I think that those are things that Medicare sees, and they want to take an opportunity to evolve. So I think for patients and the community, when they hear of these efforts to get them into the community more and have more care delivery delivered into their home, they should think very specifically, that's the stuff that my grandparents used to have to go lay in the hospital to get. And I think that's a great opportunity to receive some of those elements. Oftentimes, Marilee, when I'm working with a patient who could be in a SNF or could be at home, I'm talking to the patient about being at home. Oh, this is really going to be much better, and you're not going to have any of the problems with the SNF, including the lime green jello you get at every meal. One of the things you want to think in terms of is, if I have a nurse coming in the morning and a physical therapist in the afternoon, that's not oppressive. I don't have to do that at home. I get to do that at home. If you're in a nursing home, again, you have all the discomforts of a nursing home, and you get nursing PT and OT every day. So where historically we've maybe thought we can't provide this care at the same level in the home, I would encourage the patients and the community residents to invite that level of care into the home, because it's, again, an opportunity to receive it there, and really can connect to the functional changes that they see as they get better. What they couldn't do yesterday, they can do tomorrow because they've been working at home with home care.
Arnie, walk me through the mindset from an agency or provider standpoint at that juncture where you said we're not going to, I'm going back to your CHF example of the 5 hospitalizations, at the point where the ACO says we're not going to do the same kind of home care that we've done in the past, what's the communication or the difference in providing home care that's going to meet those needs and keep them out of the hospital versus what was done in the past?
Well, that's a really great question, Marilee. I'm glad you asked me that, because that's what I do for a living in general, is talk in terms about how we need to manage the patient differently from the home care provider perspective. So primarily, the question would change from how often did you see them, which is how many visits did you make, how many visits will we make, to what did you do during the visits. For example, if we're talking about the CHF patient is clearly behind the curve in a couple of different areas of managing their diet and of managing their water weight and just tracking those. So if you've got a nurse that's able to go into a home and get the patient to, let's say, write down their diet, and positively reinforce and work with that patient to write down their diet, that's going to be half of the first step and half of the way to what we really need that patient to do. And I think that's a skill. It's more than just laying the program expectation in front of the patient, saying, if you write down your diet every day, I think it can help you be sick less often. It's encouraging and then prompting and promoting that behavior from the patient with a number of different things. Enthusiasm comes to mind. But not all patients respond to enthusiasm. It's whatever the patient's access point is. How do we make Mrs. Smith, we'll call patient A, how do we make her understand that it's probably a meaningful trade-off to spend 5 minutes a day looking at her CHF metrics than to go to the hospital 2 additional times a year? But will Mrs. Smith internalize and realize that independently if we're not moving her towards this model? I can think of how many times, and I'm sure the number is 1,000 or more, in my home care life that I've heard home care clinicians or representatives say, that's a CHF patient, they're always going to need home care. So are we sending in a nurse that thinks that? Or are we sending in a nurse that says, my aunt has CHF like you, and she doesn't have any of these problems, and here's what she does, and let me get you doing those things? So I think that that's the difference for the provider, is to understand that we are not prepared to answer the value question of what did we do in our care delivery program. What did we do during the visit? So to reflect back to the ACO model, which says we want to do as few visits as possible and still achieve the goals, that forces the question, what happened in the visit? And when you define the visit by its content rather than the fact it occurred, what happens is 8 visits becomes 5, and 5 visits becomes 3. And I like to say that, especially for the providers, in the terms that I ask people across the country. When I present, I like to ask nurses, if you had your aunt call you and say, I just came out of the hospital and they gave me 2 new pills, can you tell me how to take them and what they do? And you like this aunt, but you're not getting paid. How many times would you go over to your aunt's house on your own time to teach you the same things about the same pills before you called your cousin and said, meet me at your mom's house because I'm tired of going over there on my own time to say the same things? And everybody across the country says 2. Yet for 2 pills on individual Medicare patients all across America, we still have the nurse charting, still teaching meds on week 3. So our thought process is, well, we make X amount of visits, and during that time we teach the meds, as opposed to we teach the meds, how many visits will that take us? And I think those are things that providers want to focus on, and I think that that's really a different angle than what traditional home care providers are focusing on today. I had a conversation with a provider of a large national group, and it's a very well-known group, and they were talking about their frustration with ACOs and hospitals, and one of the comments that they made was, and we regularly do this procedure with a patient, and we can do it for $300. And the hospital takes the patient back in the hospital to do it where it costs them $1,500. And my response to that home health provider was, oh, I understand that, and I recognize that, but the hospital's not looking at it that way. The hospital's not looking at it, well, it costs us $1,500 and it's traditionally cost home care $300. The hospital's question is it really $300 or is it $150 at home care? Because we've always looked at it through a volume spectrum. And when we look at it through a value spectrum of how fast can we get this done, that really takes on a different volume and a different cost for Medicare. And I think that's what providers really want to focus on today. And I think that's a struggle for our clinicians, because I certainly have that struggle with some clinicians, and I understand the struggle. An example is, let's say a nurse, Marilee, you know thousands of them. I know thousands of them. They are great home care nurses. They've been doing this for a decade. Maybe they've been doing this for 20 years. All of their patients like them. All of their patients get better. They just walk on water. They're the nurse that we can count on to deliver good care and to really deal with a spectrum of patients, whether it's a compliant patient or a non-compliant patient, a difficult family or an easy family. And this nurse has turned in patient programs on day 17 through day 21 for the last decade of her life, and she's been told, great job. You've got all the meds taught, great work, the caregiver's involved. And now, in her recent life, she gets some ACO patients. And they start calling her after visit 2 and asking her, do you have the meds taught yet? And she says, what's going on here? For 20 years I've been walking on water because I get everybody the meds taught. And now you want to know, do I have them done on the first or the second visit? I've always taken 2.5 weeks. And the response to the provider and to the clinician is, we want to stop worrying about the patient being readmitted for a med management error. We would like to stop worrying about that on the second visit on day 4 rather than day 17. And I think that's the challenge for providers and their clinicians, is that a rapid move to care resolution is required in order to achieve the value that we want. That's something I stumbled across early in my care private practice, but I think it's very consistent, and I think it's something that we want to think about as we rewire our agencies, and that is, if you get a patient better and make money on it, it happens fast. The longer you see a patient, the less you can change them, and the less you will be paid for it. So I stumbled across this early because I just didn't want to see patients as long as I got paid for them. I wanted to get them better as fast as I could. And that marked how I look at care delivery today, because I stumbled across that. I had a nursing home length of stay of 21 days when the national average was 56. And what happened was many of those nursing homes made so much money because they weren't paying me to see the patient till the very last day. We got them better and sent them home. All those nursing homes sold because their financials were so wildly superior to providers who took the other path and kept the patient as long as they could get paid for them. And that's when it hit me. Good care outcomes with good financial margins happen fast. And that's really what we're looking at today in the ACO model, which is Medicare's tired of spending the money or wasting the money to make sure that we don't rush anybody in their care delivery. And that's really something. Stop and think about that same model. If it takes us 10 days versus 2 days, in home care we've always thought that 10 days was correct. Put that same care concern in the same patient in the hospital and tell them you're going to take 10 days to get them out instead of 2 days. See how they respond. So I think that's really what we have to confront as we're moving forward, is gravity comes to home care, which is, of course, we want this done in 2 visits instead of 2 weeks if that's possible. And that's not something we've always been programmed to look at through the PPS era and the home health model. We've kind of been taught to look at the global patients and find things we can address that may or may not, but that may be relevant to the care outcome, as opposed to let's establish stability and safety ASAP. And that's really a different change for us. And I think I've said for about 10 years that, and I still believe this, by 2022, the average Part A post-acute home health program, I think, will be 17 days. And I think we're being led down that line by some of the new reforms like HHGM, which limits us to 30-day care plans initially.
And that's the home health grouper model that is being discussed right now. Thank you so much for listening today. And a special thanks to our sponsors and partners, Access, National Association for Home Care and Hospice, and Core Cubed. You can find more on our website, helpchoosehome.com, and on social media. Join us, won't you, to spread the word and help choose home when care is needed.